Recording in progress.
So a very good evening. A very good evening to everybody. Sorry for the delay. It's the technical issues. I hope my voice is clear right now. Is my voice clear right now?
Yes, Suspa.
Yes, it's clear.
Okay. So today's topic is basics of ultrasonography. So we know that sound is a mechanical pressure wave. So we'll be knowing about infrasonic sound waves. We'll be knowing about the sound energy that we get to, the audible range of sound that we get to hear. And then after that, ultrasound. So sound is a mechanical pressure wave. There is an audible range of the sound, which is usually between 20 hertz to 20,000 hertz. And then we find the infrasonic range, which is below 20 hertz. And there is ultrasound, which is from 20,000 hertz to 200 megahertz. So the medical ultrasound that we use is between 2 megahertz to 15 megahertz. So coming to the physics of sound, the mechanical pressure wave that is there, it travels in a medium and it is longitudinal wave. That means it travels only in one direction. And we find that there is compression in the wave. We find that there is compression and there is rarefaction. So what does compression mean? It means this is an area for high pressure. That means there are more number of particles traveling in a short distance. So that is known as compression. And then there is rarefaction. So what is rarefaction? Rarefaction is the area where there are less number of particles traveling the same distance. So sound is measured in hertz. So 1 hertz is 1 cycle, which is traveled in 1 second. And this mechanical energy has acoustic pressure, which travels in the form of compression and rarefaction. Now, there are several wave characteristics. So a few important ones is, number 1 is frequency. So what is frequency? Frequency is the number of cycles that the wave, cycles of a wave that is traversed in 1 second. Then the second characteristic is wavelength. The second characteristic is wavelength. The wavelength is the length of a wave cycle in space, or the distance from one peak to another peak, as we see in this diagram, or from one trough to another trough. Next is the amplitude. So amplitude of the wave is the height from the baseline. So the distance from the wave node to the top of the peak or the bottom of a trough is known as the amplitude. Next is the velocity. The velocity of the sound is the speed. Velocity is the speed at which the sound wave travels through a particular medium. So velocity, the units of measurement is meters per second. Velocity is the multiplied version of frequency into the wavelength. So now coming to ultrasound, how is the ultrasound, the principle of ultrasound, which is based on the piezoelectric crystals or the piezoelectric effect. So what we see is that the electrical current is getting transmitted into the piezoelectric crystals, which is present in our USG probe, and that is getting transformed into sound waves. The sound waves generates a pulse, and this pulse then reaches the tissue. And then what happens is, from the tissue, in the tissue, there's a mechanical pressure wave created. The sound wave reaches the tissue and it creates a mechanical pressure wave. This in turn, the tissue in turn creates something called as echoes. These echoes goes back and hits the piezoelectric crystals, which is present on the probe. And then finally what happens is, there is an electrical potential generated, and that is how we are able to see that on screen, in our USG screen. So one is piezoelectric effect. First is the reverse piezoelectric effect or the inverse piezoelectric effect, where the electrical energy is getting transformed into mechanical energy. And piezoelectric effect is the mechanical pressure which is generated in the tissues that forms echoes, and this echoes is getting transformed into electrical potential energy. Now, what is echogenicity? So echogenicity is the ability of the material to echo or to reflect the sound waves. So this echogenicity is seen on the screen as different shades of gray. So here, if we talk about an hyperechoic structure, it looks white and it is highly echoic. That means it reflects most of the ultrasound energy. What are the examples of hyperechoic structures? First is bones or calcium or any stones, gallstones, or pericardium or skin or ligaments. So what happens is the entire ultrasound wave hits these tissues, and the entire thing, almost at its entirety, gets reflected back into the screen, back to the probe, and that's how we read it. Then is isoelectric. Isoelectric is basically what we see is something where when the gray shades are similar. That means the isoelectric means it'll be of the similar kind of gray which is produced. The examples are kidneys, liver, and myocardium. Then what we see is hypoechoic structures, where the echoes are produced are weaker than the normal. Example is blood, and in case of effusion or any cyst. And then there's something called anechoic, where the sound, the ultrasound which is traversing, it goes and it doesn't reflect back. So we see it as a black area. So next is something called as attenuation of the sound waves. So what happens is it is the rate at which a wave beam intensity diminishes. That means when the one entire ultrasonic wave is coming and hitting a medium, the wave energy is getting lost. So how is it lost? It can be lost by 4 ways. One is reflection, then there is refraction, then there is scattering, and then there is absorption. So what we see is when we are talking about reflection, as we know that the extremely sorry for the technical difficulties here. So what we see is whenever there is an ultrasound wave that is coming and it hits the surface, there are 4 fates to the ultrasound wave that is coming. So the wave can come and it can be reflected, then it can be refracted back, and what happens is it can get scattered, or there might be So what are the types of attenuation? First is reflection. Here we see that the entire ultrasound wave, it hits the surface and it is reflected from the surface. Second is refraction. So what happens is it occurs when the sound waves move from one medium to another medium, where some of it is transmitted into the or refracted into the medium. It is lost in the next medium. Then the third one is scattering. So when the sound waves comes and hits a small object, the entire waves are scattered in different directions. So this is known as scattering. And the final fate for attenuation is the sound wave energy can be absorbed by the next material. So the second medium on which the sound waves goes and hits, that gets absorbed in the medium. Then is acoustic impedance. So what is acoustic impedance? It is the resistance to the sound as it passes through a medium. So what we see is that the higher density and higher speed of sound transmission, if it is there, then there is higher acoustic impedance. That means we have seen that the acoustic impedance means that the entire sound wave that is coming and hitting the surface, if it gets totally reflected back, it is known as higher acoustic impedance. So basically, it is a barrier which is present between two mediums. If the barrier is too high, then the entirely whatever sound wave is coming, it goes and reflects back. In our body, we have seen that the bones has the highest acoustic impedance. That is, it is around 7.8. Muscles has an acoustic impedance of around 1.71. So bone looks the shiniest, that is white in color, and muscles and even our blood vessels, it will look somewhat similar in nature. Now, there are different ultrasound modes that we use. A mode or A scan, there is B scan, and there is M scan. So A scan is what? It is rarely used though. It is amplitude modulation or mode. So it is a one-dimensional technique. What we see is that the echoes are received, the echoes received are displayed on the screen as vertical deflections. Then next is the B scan, which is the brightness modulation. So what we see is that the echo amplitude is depicted as dots of different shades of brightness or grayscale that is seen on the screen. So basically, the brightness mode is the B scan mode. So the images are built up by mechanically or electronically regulated scanning in a fraction of a second. And these images that are formed, the image rate at which the images are formed is around 15 per second. And it enables us to create a permanent imaging. And this is known as real-time imaging. So whenever we are doing a procedure, we tell that we are doing a procedure under real time. That is, this brightness keeps changing from time to time, and that gives us a real-time imaging. Next is the motion mode. So what is the motion mode or M scan? It is a way to display motion. That is part of the heart which is moving, the valves that are moving during a heart cycle. So the echoes produced by a stationary ultrasound beam are recorded over time, and it is recorded continuously. And we can see this waveform on the screen, and it depicts the movement of structures. So there are two scales. One is the horizontal axis, and then there is a vertical axis. The horizontal axis shows the time, and the vertical axis shows the position of the different anatomical structures. Next is the Doppler ultrasound. Even though the Doppler effect or the Doppler ultrasound is not used in our pain practice, but we can still use make its use for checking whether there is any blood vessels present or not. I would like to say that it is not very it isn't, we shouldn't depend on the Doppler fully, because it basically means the movement of particles. So whenever the particles is in motion, we will be able to see the Doppler. We will be able to make a use of the Doppler. So basically anything which is moving towards the probe shows as red in color, and which is any particles which is moving away from the probe is seen as a blue in color. So there are two types of Doppler that we see and we use is color Doppler imaging, and another is power Doppler. So what is color Doppler? It is based on the mean Doppler frequency shift of the scatterers. So here different colors indicate the direction of the blood, which I was talking about. Next is the power Doppler. Power Doppler is more important to us because it is independent of the angle. The previous one, which was the color Doppler, was dependent on the angle at which it is coming towards the probe or away from the probe. Power Doppler, basically, it depicts the movement of small vessels, and it measures the signal strength of moving reflectors. So small vessels or any neovascularization, if we are trying to find out, we use the Power Doppler. So Power Doppler is useful for examining small blood vessels or any low flow, slow moving blood vessels. If we need to see vascularity without the direction of flow, we just need to see whether there is any blood flow or not. We use this mode. Then for checking out any superficial structures like the thyroid, the testes, renal grafts, or subcutaneous lesions, we use this. Tumor vessels like neovascularis, and then low flow vessels are seen. Then there is the gain settings or the brightness mode. So basically, it throws more light or more ultrasound beam onto the object. We should know that it does not increase the resolution of a particular image. So we'll be coming to resolution later. So resolution means when we want to see two structures separately, we call it as resolution. So brightness mode or the B mode is basically throwing more light or making the entire screen brighter. It does not increase the resolution, and therefore this brightness mode varies, or the requirement of the brightness or the requirement of the gain depends from one observer to another observer. We can observer. So we can just simply increase the gain based on one's need. Next is the depth settings. So we should know that the higher frequency probes, that is the linear probes, usually the waveforms are higher frequency, means more number of particles are moving or more number of waveforms are being produced in a short distance. So anything, if it is near to the probe or near to the surface, that is any superficial structure, if it is present, then we will be using a higher frequency transducer. And similarly, we'll be using a lower frequency transducer in case if we want to see a structure which is more in depth. So what we usually do is this depth setting that is present in an ultrasound machine is for our ease. We need to, on the right side of every screen, we are able to put the depth. So if we want to see a structure at 3 centimeters from the skin surface, we should be setting the mode at 3 centimeters. If we want to see something which is much deeper than that, we'll be setting the mode at say 5 centimeters. So basically, we don't want any unnecessary space around the particular structure that we want to see. And if my structure is present at 3 centimeters, I would want to make the depth settings at 3 centimeters, or maybe 1 centimeter beyond whatever the deepest structure that we want to see. Now, one important thing is time gain compensation. So what is time gain compensation and how is it different from the depth? So basically what we are trying to do is we are trying to brighten up or increase the gain in one particular area. So time gain compensation selectively amplifies the echoes at different depths. It is almost similar to increasing the overall gain, but then overall gain was increasing the brightness of the entire screen. Here, to make our job easier, we are doing the time gain compensation so that light beam, or maybe say the brightness, goes and increases in the particular area which we want to target. Next is the focus. So focus, as we know, is the entire energy is getting focused in a streamline and falling onto a particular area. So focus should be set or at an area of interest. It improves the lateral resolution. So I will be coming to resolution, which means 2 objects which are kept at equal distance or at equal depth. That is known as lateral resolution, and that improves when we increase the focus. So a beam's primary area of focus is being targeted here, and improper placement can cause blurring of the field nearby. Okay, and multiple focal zones can be set. Multiple focal zones will increase the resolution of the entire image. And each focal zone is represented in a single scan line. Then resolution. Resolution is mainly lateral resolution and axial resolution. So lateral resolution means that the ability to distinguish between two reflectors or two objects which is situated side by side at the same depth. So lateral resolution is affected by depth. It is affected by the frequency of the beam. Like in my previous slides, when I was explaining, I was telling that the frequency of the beam means it goes till a particular depth of the substance. So higher frequency will travel lower distance, and lower frequency will travel a higher distance. So the lateral resolution is affected by the frequency of the beam, and then it is affected by focal zone placement, and it depends on ultrasound beam width. Next is the axial resolution. So axial resolution means when we want to see two objects which is coming at different depths. The beam which is falling, we want to see two objects at different depths, and that's when our axial resolution comes into play. So axial resolution is the ability to distinguish between two reflectors situated in direction parallel to the ultrasound beam. So the ultrasound beam is coming from top, and if any object is lying in the same path, we call it as axial resolution. And this axial resolution is influenced by ultrasound frequency and also the length of the ultrasound pulse, which is being emitted from the ultrasound transducer. So now coming to the transducers. So what does a transducer do? We have spoken about it in my earlier slides. So transducers has one patch which contains some element which has piezoelectric property. So what is this piezoelectric property? It has that property of transmitting or transferring mechanical energy into electrical energy, and that's when we call it as piezoelectric effect. And when this opposite thing is happening, that is the electrical energy is coming back to the tissues and then mechanical energy is formed, that is known as the reverse or the inverse piezoelectric effect. So the transducer receives the resulting echo and it converts it into electrical energy, and this may vary. This transducers, as we know, may vary in size, the shape, the frequency, and the field of view. So basically there will be linear probes. All of this will be demonstrated later on. So first there is linear probes, then there is curvilinear probes, and there can be hockey stick probes. So basically what we see is, if in case of a linear probe, the higher frequency is normally transmitted. In case of a curvilinear probe, lower frequency is transmitted. And in case of a hockey stick probe, basically it is a linear probe with the area of magnification or the footprint in a small area. So basically it is used, the hockey stick probe is used to visualize superficial structure, say suppose the peripheral nerves of upper limb or lower limb. When we want to see a particular nerve or a particular vessel, we will be using the hockey stick probe. Now the same thing. So linear array, what it is, the frequencies is higher frequency, that is 7 to 17 megahertz of energy that is used. It gives us a higher resolution. The rectangular, the probe, the linear probe gives a rectangular footprint, and it is good for scanning a wider range of view. The rays that is coming out from this linear probe is in the same line. It is in parallel lines. And structures which we usually see is musculoskeletal structures, or any superficial structures can be seen, even vascular. So in anesthesia practice, we can use a linear probe, or we can use a hockey stick probe to find out a particular vessel for cannulation. Next is the curvilinear probe. So a curvilinear probe is used to see something which is placed at a more depth. So in case of when we want to check the abdomen of a patient, we would use a curvilinear probe, or any structure which is present at a higher depth will be going for curvilinear probe. So here there is higher resolution. Then deep penetration is there with lower frequencies. So deep penetration, how? If when we were studying about the waves, sound waves in the beginning, we have seen that when bigger waves are lower frequency, that means the number of waves which is traversed in 1 second is less. So that means that the sound wave is traveling more distance. So that means that is, it gives us deeper penetration. So deeper penetration is possible at higher frequencies, and it is trapezoidal in nature, as we see in this diagram. It is spreading from the end of the transducer and towards a wider area. So what are the structures seen? Deeper organs, transabdominal pelvis, neonatal, in a pregnant woman, we can use to see the abdomen. We can use this probe. Then transducers, same thing I've been talking about, the different types of transducers. Then when we are scanning, this entire thing will be demonstrated later on. So when we are scanning, we can scan the patient in a sagittal scan, in a coronal scan, and in the horizontal plane. So when we are seeing, we are making a section in the cross sectional, the horizontal scan, it divides the body into upper half and lower half. Then when we are making a coronal section, it divides the body into something that is in front and something which is at the back. And when we are dividing it into a sagittal scan, it is dividing into the right half and the left. So this sagittal plane, how it is helpful in our USG. So when we are doing a long axis scanning, the sagittal plane, the concept comes into view. When we are doing a short axis scanning, which is basically placing the probe perpendicular to the structure that we are seeing, then the horizontal plane comes into view. And then aspect marker. And aspect marker is basically to give you an orientation, as in which side of the screen is corresponding to which part, or which side, the medial side or the lateral side of the body. And one thing we should remember is aspect marker, the ease of the aspect marker is based on the user. So if I want to see the lateral side of the body on the aspect marker side, or on the lateral side of the screen, that is totally up to me to decide which side of the aspect marker I will be using as in reference to which side of the body that I am scanning. And so short axis and long axis. So when we are placing, say suppose we are placing the linear probe in parallel to in parallel to our humerus. So that is seeing the humerus in the long axis. When we are placing the probe in a perpendicular way, then that is seeing the humerus in a short axis. So this is the concept of long axis and short axis. This again will be shown by Sir in the subsequent part of the class. Now, probe manipulation. I'll just mention these and it will be demonstrated later. So basically, when we are changing the long axis to short axis, or the short axis to long axis, we just need to rotate the probe. We can rotate the probe in a clockwise or an anti-clockwise direction. Usually the anti-clockwise movement of the probe is preferred. And then there is something called heel-toe maneuver. It's nothing. If we place say suppose this is the bone and we are placing the linear probe in the same parallel axis, then that is, and if you press one end of the probe onto one side, and say suppose on the lateral side, and we leave a little bit of less pressure zone on the other side, then it is known as the heel-toe maneuver. And then when we are pressing the probe onto the tissue, that is known as compression. And toggling is basically changing the angle of the probe on the body of the patient, and that's how we are getting a clear image of the structure that we want to see. So body habitus and transducer choice is basically an obese patient. You will be using a curvilinear. Say, suppose you want to check a huge fat abdomen of a fat patient. So you will go for a curvilinear probe. So we are using lower frequencies. And when we are seeing any structure which is present superficially or a lean and thin patient, we will be going for a higher frequency probe. So hand positioning, we should be knowing that the hand position is very important. And when we are, as seen in this particular diagram, when we hold the probe, we will be holding it with our two fingers. So our thumb and the index finger, we will be holding the probe, and the rest of the three fingers will be rested on the patient's body. Then the concept of acoustic windows. So acoustic window basically in simple words means when we are seeing a particular structure through another structure. Say, suppose we are seeing a particular structure through a blood vessel, then we will be able to see that area much brighter. So acoustic window, we have seen that intercostal scanning when we are doing, it gives a good acoustic window for seeing the heart, the kidneys, or the liver. Next is artifacts. So artifacts again will be dealt in detail later. So artifacts, there are different kinds of artifacts present. Ultrasound machines are programmed to assume artifacts. So the sound travels in an average speed, and the sound and the returning echoes, which when the sound goes and hits and then that echo is traveling back, it travels back in a straight line. And when that is scattered, that is multiple times if the beam is going and coming back, it produces an artifact. Various artifacts that are seen will be demonstrated later. Then noise or speckle is basically another artifact where there is a granular texture or an unclear image that is seen, and it is mostly seen in case of solid organs like kidneys and liver. Then there is something called posterior acoustic enhancement, or PAE. Here, what we see is the sound beam travel through fluid-filled structures, and the echoes distal to the fluid become brighter than the surrounding structures. And we can mask this can mask the free fluid or any other pathologies which is present due to the posterior acoustic enhancement. And this can be decreased if we can use the time gain TGC compensation mode, which is present in our ultrasound. Next is reverberation, the one that we were talking about. If we are seeing multiple structures from getting reflected from the needle which is being placed onto the patient, we call it as reverberation. Then the in general precautions that we should be keeping in mind while we are using the USG. So the infection control and then contact precautions and isolation measures should be followed when we are using the ultrasound machine. It should be used in a sterile field. So what we use is we take a sterile covering, we make a hat or a probe cover, and then that probe cover will be using gel and using the probe onto the patient. Then the ultrasound should be used in a sterile field. That is, when we are using, before using the ultrasound, the entire patient area, the skin should be cleaned, and strict aseptic precautions should be followed in case of using an ultrasound. And we should keep in mind that the ultrasound probe that we are using should be covered with a sterile cover, and in no way chances of infection should be stopped through this. So the general tips for scanning is we should scan slowly and use only one motion at one time. We should try to fix off the axis and then manipulate the patient's positioning. Always consider the patient's comfort. Also keeping in mind the ergonomics, as in where you are keeping the patient, where you are positioned, and where your machine is positioned. Then point cephalically when the scanning is done in a longitudinal scan, and then point towards the patient's right when scanning transversely. So basically, this is the using the aspect marker in a careful way, so that you understand which side of the screen is which side of your aspect marker or the patient's body. And point of care ultrasound is intended to to see all this, the clinical aspects is seen through this point of care ultrasound. And that's the end of my presentation today. Thank you. Now we'll be moving to demonstration. We'll get the volunteer ready and the demonstration is going to start. Thank you.
Sir, you are mute, sir.
Am I audible now?
Yes, sir.
Okay, so earlier I was not audible.
Yes, sir.
Okay,
Yes, sir.
I thought, okay, I'm audible. Thank you so much. So anyway, so what I was trying to tell that whatever the physics part, the practical application and the machine part I'll be showing you, I'll be demonstrating you on the volunteer, and also I'll be showing you the needling technique, how you can visualize the needle best possible way. So let me share the screen first. My screen is visible?
Yes, sir.
Okay, thank you very much. So the other few things what I'll be showing you. One is your the depth. So this is the ultrasound screen what I am showing here. And you see on the right hand side, again, the different machine, this machine what I am using here is a touchscreen machine. So everything is on the screen. You can the touch there and you can change the things. But basic aspect of all the machines are almost similar. So one of the important aspect is what Shushma already told is depth. So depth means, on the right hand side, you can see the depth button is there. So 1, 2, 3, 4, 5, 6 centimeter. And you can see here by increasing it, I'm increasing the, decreasing the depth, and by sliding it down, as I told you, because it is a touch screen. So I'm doing it here by sliding it. I'm keeping it in the 4 centimeter. So one is your depth button, every machine, and the depth is very important part. And always try to, optimize your depth. Suppose you are looking something around 2 centimeter and your depth is at 4 or 5. So don't do that. You will not be able to visualize the structure nicely. So try to keep it, minimize the depth when you are using the superficial. When you are going to work on the deeper, try to increase your depth. Then important part is your frequency. Frequency, again, many of the machines has the auto frequency, and detailed use of the frequency normally done by the application manager. And nowadays, almost all the musculoskeletal ultrasound machines where the presets are there. Means if you are going to the MSK, they'll be giving you the different options. Whether you wish to scan on the shoulder, whether you wish to scan on the hip, on the knee, ankle. In that way, there is presets where the frequency and everything is set. So that, you need not go, just, it is much more user friendly. In this machine, so detailed frequency is not needed, but here you can see one is your high resolution. High resolution means here the frequency will be higher so that you will be able to see the superficial structure, like up to the, 2-3 centimeter very nicely. And if you are making it in the frequency, the high general means, as a whole, it will be the mid-range frequency, and there is a high penetration. High penetration means it will be the lower frequency. That means most of the ultrasound probe what nowadays we are using is not a fixed frequency. It's normally something between it varies. Like here you can see, here we are having in this machine right now there are 3 probes are applied. One is your calvirinear probe, and you can see the frequency range is from 1 to 5. 5 is the frequency, 1 to 5 gigahertz. Another is your mid-range, where the frequency is 4 to 12. And another what I am now attached is your 4 to 20. That means the frequencies can be changed from 4 megahertz to 20 megahertz. 20 megahertz is very high frequency. To see the very superficial structures, the best is around 20. We are also having the hockey stick probe. So here it is not attached. So this is a hockey stick probe. Hockey stick probe is also high frequency probe. Normally the hockey stick probe is approximately your the 20 megahertz probe. But here other probes are also available, like high frequency probe I'm using. It's not a hockey stick probe, because hockey stick probe has some limitations that its footprint is very small. But what you are using here, it is very high frequency probe, but its footprint is broader. So normally this machine, what kinds of probe what I am showing you, these are the best 3 possible probes. One is your very low frequency for the deeper structures to see. One here, this is the mid-range, means something around 4 centimeter to 6-7 centimeter. For this mid-range, 4 to 12 megahertz is the best. And to see the very superficial structures below 4 centimeter, so up to 12 megahertz probe is the best. So the frequency depends on, as I told you, preset, but frequency, if you are wish to examining the superficial structures, make the frequency higher. If you wish to examine the deeper level, make the frequency your smaller. But here also you have to remember, when your frequency is higher, your resolution is also very good, very high. And when your frequency is lower, your resolution will be little less, resolution will be compromised. Then is your gain. Already Suspa has told the detail about it. Gain means overall increasing the brightness. Like any picture, when you are changing the picture, then you are increasing the gain or decreasing the gain, means increasing the brightness, overall brightness. Like here you see, I'm showing you here, I'm putting on the gain button, and I'm putting, just let me, how the gain is increased on the volunteer. So you can see the structure here, and I'm freezing it. And now see, when I'm changing the gain, so overall it is becoming brighter, or overall it is becoming. So no, it is not, not changed any particular area. So this is your gain. And again, it is depends on the person to persons, how a examiner is to look at. Whether the brightness, he likes the more brighter structures or less brighter structures. But normally we should be adjusting it something around the mid-range that gives the best visibility of the structures. Focus button, many ultrasound machine nowadays is has no autofocus. So where the multiple focus areas are there, and it will be giving the best kind of image with the autofocus. This machine is having the autofocus, but many other machines, we are having the other machines where you can focus it. Suppose you wish to see something around the depth of the 2 centimeter structures. So what we'll be doing, we'll be sliding the changing the focus button. You can change the focus button superficial or deep. So what you will be doing, suppose you wish to see something at the 2 centimeter depth, so you will be adjusting your focus button so that it is coming here. But some machines, the focus is autofocus, so there you need not bother about all those changing the focus. And some machines are the dual focus. Means suppose you wish to see something at a level of the 1 centimeter and another 3 centimeter. So there is a 2 focus button. One you can do it as the 1 centimeter, another at the 3 centimeter. So focus, what already Suspa has nicely demonstrated in his the lecture, that here the ultrasound beam, sound beam are concentrated more over that particular area, so that those structures looks, resolution becomes better. This is your focus. Then your TGC, your time gain compensation. So here is a TGC button. You can see if I'm pressing over the TGC button. So on the left hand side of my screen, I'm just sliding this side of the screen. So here, you can see that I can increase the gain at this particular area. You can see here I can increase or decrease the gain at that particular area. I can increase the decrease the depth at that particular area. So that means TGC is almost like that of the your gain, but here the time gain compensation means you are particularly dealing with a the gain in a particular area, not the whole screen. So whole screen, if you wish to increase the gain, then you should be going for the gain up and down. But time gain compensation means that you are increasing the gain or decreasing the gain at a particular point, at a particular depth. Now, why it is called time gain compensation? Why time comes, time gain you can understand, but why time question come? Because here the ultrasound, machine, what it understand that it is based on the time when it is coming back. Based on that, the machine determines the depth. The things which are, because it's coming very quickly means it is coming from the superficial structures. And if something is coming little later, that means it is coming from the deeper structures. So time gain compensation means that you are compensating or changing the gain depending on the time or depth. Here, time is equivalent to depth. So you are changing the gain at different depth. So you understand why we're calling it time, because depth is determined by the machine as time when it is coming back to the time. So back to the machine. So time gain compensation. Then is your, the color Doppler is one of the things which is very useful for us. Like here, if I am holding it and I'm giving color. So here you can see the structures again, which is coming towards your ultrasound probe will be looking red. Away it will be coming your it will be coming as a blue. And another is your power Doppler. So power Doppler is if you wish to see a particular structures, at a very tiny vessels, then you can use the power Doppler. So here I'm just showing you how the power Doppler. So this is my structure of interest is here. So I'm putting it here and I'm making. So you can see there will be sound and there will be pulse waves. So with that, you can understand that this was a vessel. So the mode already Suspa also told A mode. A mode means you are just linear single dimensions. B mode, M mode. M mode is mostly used by the cardiologist. B mode is the what we are normally using, and also sometimes the color and the power Doppler what we are using. So then what is important is a freeze button. Very important. I always, in our OPD, we are having the ultrasound machines. We are always using any patient after our clinical examinations. We are always using the ultrasound to see any other structures abnormality. And almost every day I scold our fellows that, okay, why have you not pressed the freeze button? So it is very important that unless you are freezing, the piezoelectric crystals are continuously firing, and the half-life of the crystals will be decreased, and after sometimes continuous firing, the pictures also gets distorted. So whenever you are using, only then I forgot to put the freeze button. So let me put the freeze button. So when you are not using it over the body, always put the freeze button on. Then you can increase your half-life, then your picture quality will be better. And another important thing is your measure. So most of the is having the measurement button is there. So here also we are having a measurement button here, the measure. So measure button when you are using, so it will be coming. So here one and again another, you can measure another side of the screen. You can see what is it is 0.8 centimeter. And here also you can see that you can see area when you are, like if I am going for the area. So from here, I'll be like this. I can measure the area, the square centimeter patient or square millimeter. It will be given by the machine itself. So these are the important practical application, and I'll be demonstrating now the other things as well. So before that, another important things about your probe. So I'll be showing you the different kinds of probe, what are the different uses, and the aspect marker in a probe, and different orientations when you'll be again starts the scanning. Then I'll be showing those things again. So the types of probe, there are different types of probe, but for the pain physician with the musculoskeletal ultrasound, these three kinds of probe is important. Already I have shown you that one probe is your curvilinear probe, And this is for the deeper structures. We are not, abdomen is not our area of the interest in the musculoskeletal ultrasound or the chest. The most important areas where we are using the curvilinear probe is the spine, particularly the lumbar spine. Lumbar spine, when we'll be demonstrating, we will be seeing that mostly we are using the curvilinear probe because the structures at a deeper, like if you used to examine the psoas, if you used to examine the lumbar plexus, then we have to go a depth of approximately 7-8 centimeters. So anything more than 6 centimeters, 7 centimeters, you have to use the curvilinear probe, otherwise you will not be able to see these structures nicely. So mid-range, as I told you, that something approximately 3-4 centimeter to 6-7 centimeter, the 4 to 12 megahertz probe is the best. And the two examining the most superficial structures, 2 centimeter, 3 centimeter, up to 4 centimeter is your 20 megahertz probe or hockey stick probe. Normally hockey stick probe frequency range is something up to 18 or up to 20 or sometimes even 22 or 24 megahertz probe is also available. But with this 20 megahertz probe is also quite good, and resolutions becomes very nice with the 20 megahertz probe. So there are 3 different types of probe what is used. One is your low frequency curvilinear probe. One is mid-range up to 12 or 14 megahertz. Another is very high frequency up to 20 or 22 megahertz probe. These are the 3 different types of probe how we are using. So now in a probe, you can see one important aspect, is your this side. You can see there is a marking there, and this is called aspect marker. So what is aspect marker? Let me bring this screen here. You see here there is written as G. Normally the aspect marker is by the company's logo. Here it is G. So here if I'm tapping on this side, you see here if I'm tapping on this side, you see this was the area. If I'm tapping on this side, then on the left hand side is, so normally, not normally, it is always that the aspect marker will be on the left hand side of your screen or monitor, and accordingly you have to place it. So if your aspect marker, suppose in this patient, if you have an aspect marker is on the, you see on the this side, on the right side, left side of the screen, but that is on the patient's lateral side, or whether it is on the medial side. So it depends on that. So when you're putting it, you always keep in your mind that which side is your aspect marker. Or sometimes we use, just now what I did is you're tapping the gel over the probe and you can see it. But again, a good practice is always looking at the aspect marker on which side, keeping that in mind that that side will be the left side of the screen of the monitor. Then is the how to hold the probe. Again, Suspa has already told it nicely. So you have to probe like a holding your pen, two finger or maximum 3 fingers sometimes, and these 2 or 3 fingers must be fixing your probe and hand in the patient body. Otherwise, what will happen? The longer way to hold the probe, don't hold the probe like this. Don't hold the probe like this. So holding the probe will be like holding a pen. 2 or 3 fingers, and rest 2 or 3 fingers should be fixing with the body, and you have to, so that you can manipulate the probe very nicely. There are different manipulations already Suspa told, and I'll be also showing you. So you can use the probe best if you are holding the probe with the 2 fingers and fixing your hand with the patient's body with another 3 fingers. Then this is a little bit about the probe. Then the probe manipulations. So probe manipulation, what are the different kinds of probe manipulation? One is your rotation. And before rotation, what was already discussed is the long axis, short axis. Long axis means, suppose this is the hand, and if I am holding the probe like this, so this is short axis. And if I'm holding the probe like this is your long axis. So the making from the short axis to the long axis, or long axis to the short axis, this is called probe rotation. And many a time what happens, we used to examine the structures both in short axis as well as the long axis. So like a nerve, like a tendon, we used to examine both in the short axis and long axis. For that, we need to rotate and always keep your targeted structure in the middle of the screen, and then only gradually we rotate from the long axis to short axis or short axis to long axis. Then important thing is your compression. Compression means you are compressing the probe. Particularly, this is important when you are very much want to be sure that whether you are over the or the vein or a artery. So vein is easily compressible. Very little pressure is going to compress it, and artery is not that compressible. So based on that, you can understand whether it is. But other application of the compression is also there. Suppose you are dealing with a very obese patient and the structures, your targeted structure is very deep. So you can place your probe of the patient body so that your target structures come closer to your probe and you can do it better. So that is also a compression technique sometimes used in a very obese patient. Otherwise, another important is a compression is here to understand the probe tenderness. Means in the tender area, when you are examining, you just gently press over the targeted area or the suspected area and see whether that is creating tenderness or not. So these are the areas. This is the application of the compression. Next is your toggling. Toggling means suppose I'm holding the probe like this, and what I'm doing, I'm toggling, I'm changing the angle in a fan-shaped manner. See, I'm just showing you for that I'm showing, but ideally I should be holding the probe like this. So if I'm doing like this, so this is your toggling. So you're changing the angle, and many times you need to toggle it. Suppose you are putting a needle and you wish to see the visual, unable to visualize the needle. So the very important technique is just toggle a little bit, and you'll be able to see your needle. So the toggling or fanning is a very, very important thing. Sliding is also similar. When you are unable to see your needle, just slide a little bit up and down, rotate a little bit, and you will be able to see it. Another important thing is your heel-toe maneuver. Heel-toe maneuver means, I'll be coming to this heel-toe maneuver when I'll be showing you the needling technique over the gel. I'll be showing you heel-toe maneuver is in one way means you are lifting the one side, and another side you are one side you are lifting and another side you are compressing. So that is your heel-toe maneuver. So this is your heel-toe. This is your heel-toe maneuver. So you are lifting, compressing the other one side, and you are lifting the other side. Now, why it is important? This is important to make your, the structures, the more is better. Like, say for example, if I'm just try to explain it with the annotation, what exactly is the heel-toe maneuver and how you can use it in a better. Suppose this is your ultrasound beam probe. This is your ultrasound probe. So, and this is your needle or any desired structure. So when you'll be able to see it better? Because ultrasound beam is what? That if it is coming this way, reflecting back, then you can see it better. Your angle is like this, then it will be coming like this and it will be deflecting back like so. This structure will be looking anechoic, not hyperechoic. This structure will be looking hyperechoic. This structure will be looking anechoic because ultrasound beam, what is focusing over coming here is reflecting back to the other side and not going back to the beam through the ultrasound probe. So to see a structure hyperechoic, the ultrasound, the wave must be coming back to your probe. Then you can see it as a hyperechoic. If a structure, if the ultrasound beam is going away from it, then it will be looking anechoic. So to see a better, what you can do, you can make the probe by heel-toe maneuver. You can make it put like this, or you can give a lot of gel here, and you can make it in this side, and you can make it. So by that way, trying to make the ultrasound am I audible now? Hello? Am I audible
Yes, sir.
now?
Yes, sir. Yes, sir.
Okay. There was sudden, loss in the internet connection. That's why there is a problem. Anyway, I'm sorry. Up to which, where I was talking? I was talking the heel to maneuver, isn't it?
Yes, sir. Heel to maneuver.
Yes. So what I was trying to explain that the heel to maneuver is to bring the ultrasound footprint parallel to your structure so that the majority of the ultrasound beam is coming back, reflecting back towards your probe, and you can see that structure's bright. If it is going to the other side, it will be lost and it will be looking as an anechoic structure. So by heel to maneuver, you can see the structures better. Even the heel to maneuver will be very important when you are using, when you are manipulating a needle. Then important is your the different tissue characterization. So I'll be just holding my probe over the volunteer, and I'll be showing you the different structures there. So first, let me make it very superficial so that you'll be able to see it better, decreasing the depth. So the most superficial structure is your what? I'm freezing it. Just randomly, I'm holding it. So you can see some structures here. So what are these structures? So this structure is your looking what? This structure is hyperechoic structure. So this is a hyperechoic structure. This is what? Skin. So skin looks hyperechoic. After that, this
Not
structure.
able to see the screen.
Pardon?
Not able to see the screen. What you're showing. Pin and all.
You cannot see the screen?
No.
No, sir.
Oh,
We are
sorry.
seeing you.
Oh, sorry. I have to share it again. My internet connection was lost. I'm extremely sorry. I'm just sharing it again. Okay, can you see it now?
Yes, sir.
Okay. So what I was showing first that this hyperechoic area was your skin. Okay, this area. So skin looks hyperechoic. Is it clear to everybody? This area is your skin. Clear? After that, there is a hypoechoic area with some hyperechoic connective tissue septa. So what is this? This is your subcutaneous fat. So fat looks black. Fat looks hypoechoic. So acoustic impedance, Suspa in her slide has shown that the blood vessels, the fat, they are having the very low acoustic impedance. Acoustic impedance means what? That means how the ultrasound beam is reflecting back. So fat has a poor acoustic impedance. That means here the reflected the echo is very less, so it will be looking black. Anything what is reflecting black is nicely, that is looking hyperechoic. Anything what is not reflected back will be looking hypoechoic. These are very simple things, very simple principles in the ultrasound. So here the fat, because its acoustic impedance is very less, so the ultrasound beam will be passing very nicely through it and it will be looking black. But in between, there will be connective tissue septa, like what you can see here, the white areas within the fat. This is a characteristic of the fat. As a whole, fat will be looking white, and within that, there will be black area, white area, that is your fatty tissues. Then what you can see here, you can see is a blood vessel. And as we saw earlier also, to check the blood vessels, if you're having the problem to identify, you can do a Doppler scan also, power color. You can put the color and you can see whether it is a blood vessel or not. Then another structure, what you can see here is you can see that here nothing is seen. This is called the acoustic shadow. So here the ultrasound beam this is looking hyperechoic, and after that we can't see anything looking black, anechoic. That means this is a bone. So how a bone will look? So bone will be looking as a anechoic structure, and it will be covered by a hyperechoic structure. Then comes the nerve and the muscles and tendons. So here, let me clear the drawing. So at the center of the screen, what I can see here, again, a lot of jelly always to be used liberally so that you can see the structures nice. So at the center of my screen is your what? Median nerve. See how I'm holding the probe, where I'm holding the probe. So how it, and how it is different from the surrounded structures. I'm freezing it. I'm keeping it at the center. So here you see that here there is within a dark background. So we are having the hyperechoic dot, and it looks like an honeycomb structures, honeycomb-like appearance. So this is your nerve. So nerve and tendon might be looking similar, but this and this look similar. But the difference here is the contrast between the white and the black is much more prominent with the nerve than the tendon. So, and also if you're toggling it, the tendon will be becoming, the anechoic. No, you cannot be able to see the tendon. No, it is not always hyperechoic. It will be becoming hypoechoic. But the contrast in the nerve will remain same. So I'll be just showing you again and try to understand here the difference between the tendon and you see here the median nerve in the middle of the skin, which is looking like a, the honeycomb-like appearance. And on this side also you can see some structures, which is also looking like a, this is the nerve and this is the tendon, which is looking like the similar structures. But see, I'm toggling it. If I'm toggling it, see, this is becoming hyperechoic, but here this is the contrast here is always remaining same. See, the honeycomb appearance means contrast between the hypo and hyper. For the tendon, it is becoming, anechoic, hypoechoic, but the nerve change is there, but not that much change in the nerve. So that means nerve and tendon. So here, the more hypoechoic within that, there will be hyperechoic, honeycomb-like appearance, and that will be, not changing much with the toggling. Whereas the tendon will be changing much with the toggling. And also, how we'll be seeing the nerve in a long axis. So I'm keeping in the middle of the skin. I'm rotating. As I told you, rotations, how to rotate. Keep the tendon in the middle of the, keep the structures in the middle of the screen. Here I am putting the nerve in the middle of the screen. And I am now seeing the median nerve in the long axis. So this is the median nerve in the long axis. Okay, so this was muscle, this was nerve, and this was tendon. So what is the difference between these two? So here and here again, both are looking similar. Both are looking similar. You might be, confusing it very much. We might be, many times you might be confusing whether it is a tendon or whether it is a nerve. But what I told just now, the contrast is, dark and the bright area. The contrast is much more with the nerve rather than tendon. But otherwise, they might be looking similar. So again, I'm showing you again from the short axis. This was the nerve in the middle of the screen, and now I'm making it in the long axis. Long axis. So the nerve is above, and below that is the tendon. But in the nerve, the hyper and hypoechoic contrast is much more than the tendon. But otherwise, you might be making mistake. Which one is nerve? Which one is mistake? Which one is nerve? Which one is your tendon? So the nerve is having the more contrast rather than tendon. And tendon, if you are following the tendon, tendon will be gradually becoming the muscle. So I'm following the tendon, you see this is gradually becoming the muscle. So always all the tendon gradually will become muscle. How your muscle will look? Muscle in the short axis here, you see, is like a starry appearance. So here again, see, this is the muscle. So the muscle will be having the again what is the basic structure of a muscle? That there is endomysium, individual the muscle filaments are covered by the endomysium, and few of the endomysium is covered by perimysium. So what this white structures we can see is your perimysium, and then entire this is covered by on the epimysium. The same for the nerve also. When you see the nerve also, I just, so here it was the median nerve again. So here also the above cover, this cover is your epineurium, and then white structures what you can see is your epineurium, and the white is your the perineurium, and endoneurium is very thin, we cannot see the endoneurium. So the few bundled together is covered by the perineurium. So this the white structure is your perineurium, and the overall structures the covering is your the epineurium. The same way when you are looking at the muscle, so muscle also the white structure is your study appearance, that is your perimysium, and covered by the endomysium. So this is how a muscle will look. So muscle also in the long axis, you can see this is the long axis of the muscle, and this was the short axis of the muscle. Short axis, it will be looking like a starry appearance in the black sky, and in the long axis, you'll be able to see the muscle fibers, particularly the perimysiums, and going along this these white structures going long is your perimysium. So blood vessels, already I showed it will be pulsatiles, and if you are having any problems with identifying, looking at the pulsations, if you can still having the confusion, you can use the Doppler. Either you can use the color or you can give the power Doppler. Then one important thing what I'll be showing you is your fibrocartilage and hyaline cartilage. Both are cartilage, but the difference between these two cartilage is hyaline cartilage will be looking black and fibrocartilage will be looking. So here Suspa, can you hold the camera towards this volunteer? So this is another volunteer. So I'm holding the probe here for the shoulder from the posterior aspect. No. Hand. আরেকটু হ্যাঁ ঠিক আছে আরেকটু না এদিকে করো উল্টো দিকে আরেকটু উল্টো দিকে এদিকে হ্যাঁ ঠিক আছে so the shoulder, so here what you can see here is your I'll be just shoulder. This is not the shoulder class, just to show you the two types of cartilage here. So here you see so you see here, this is your humeral head, and this black area is your hyaline cartilage. So hyaline cartilage looks black. This was the glenoid, and this was your labrum, and labrum is your fibrocartilage. So fibrocartilage looks hyperechoic, bright white. Meniscus is a fibrocartilage, will be looking bright white. Acetabulum labrum, fibrocartilage, you'll be seeing as a bright white. Here also glenoid labrum, we are seeing as a fibrocartilage bright white. Whereas the hyaline cartilage, again hyaline cartilage also will be showing in the different structures when different joints will be showing will be seeing the hyaline cartilage also. It will be looking hypoechoic, dark. That is your hyaline cartilage. And bursa again, normally bursa will be a black line, but bursa is very difficult to visible unless there is a bursitis and the accumulation of the fluid. You will not be able to see the bursa. Otherwise, you'll be seeing bursa as a thin black line. Within the white area is your bursa. So these are the different, the tissue character, and next is your artifact. So what is artifact? I'll be showing you these are the different kinds of the artifact. So, and sometimes we are utilizing it. Suppose you are holding it, and see here, I am seeing only the half of the screen. This side of the screen is not visible. Why? Because I'm not holding them properly and I'm not put the jelly. So this is one of the artifact It is your inadequate medium. I have not given the good jelly. I am not holding the proper nicely. So you have to put a lot of jelly, particularly when the surface is smaller, when the surface is uneven. Suppose you are going to examine the ankle, the malleolus, medial malleolus, lateral malleolus, there is depression. Unless you are filling that depression with the adequate jelly, you will not be able to see it. So put good amount of the gel before going to examining that. Next important thing is your acoustic window. And before that, another is your acoustic window, what already Sushma has told. Acoustic window means when you are seeing structures through other structures, or seeing structures in between two hypoechoic structures, in between two bone, we are seeing that is the acoustic window, or we are seeing structures through some structures. We call it as an acoustic window. And important thing is here, we can see through the thyroid, we can see something through the liver, we can see something through the blood vessels. That is your acoustic window. Acoustic shadow means like bone is a, when you are looking at the bone, I show you that you cannot see anything, that is an acoustic shadow. Same way, if there is a calcification, there will be acoustic shadow. Acoustic shadow means there is a, the acoustic impedance is too high and everything is, nothing is penetrating that and everything is coming back. That is your acoustic shadow. Posterior to that, you are unable to see anything. Then is your acoustic enhancement. What is acoustic enhancement? Acoustic enhancement means when the ultrasound beam is going through some structures which has a very low acoustic impedance. Say, for example, blood vessel. And you will be able to see the structures beyond that in a very bright. That is called acoustic enhancement. Like if you are seeing some structures through a vein, or suppose here, I'm just holding it over a vein, cephalic vein. Okay, so what you can see here, that this area is looking brighter. Why? Because when the ultrasound beam is coming, in this area, it is, some of the ultrasound beam is reflecting back, but here nothing is reflecting back because the acoustic impedance is very low. So suddenly it is going to a media where the acoustic impedance is higher. So this area will be looking brighter. And you can utilize it to see some nerve. If you are looking some nerve under the vessel or some tendon under the vessel, that tendon or that nerve will be better visible. Many times like distal biceps tendon, very difficult to visualize. But if you are visualizing it through the brachial artery, it will be looking very bright. Here also in the wrist, the superficial branch of the radial nerve also can be seen very nicely through the cephalic vein. I'm just showing you how the cephalic nerve, normally superficial branch of the radial nerve is very thin, but when you will be seeing it, I'm just trying to show you. You can see, can you see something, some black honeycomb-like appearance just below the cephalic vein? So that is your, so it is now seen much brighter because of the acoustic enhancement. So this is acoustic. Can everybody appreciate my superficial branch of the radial nerve just below the cephalic vein? Yes?
Yes, sir.
So this is the superficial branch of the radial nerve, just below the cephalic vein. It is better seen. Why? So this was your this was your nerve. So because there was acoustic enhancement, and there I am seeing the nerve through the blood vessel, so that I can see it better. Next is your anisotropy. Anisotropy means, as I already explained, that when it is reflecting and not coming back, reflecting and going away, then that will be looking as a anisotropic. And many times we confuse it, thinking that it becomes hypoechoic, there is a fluid, sometimes you make a confusion. So always toggle it and see whether still it is looking dark or not. If it is still looking dark, then you understand that there is some, the pathology is there. Otherwise, you have to think that there is an anisotropy. So anisotropy, always keep in mind that anisotropy is the reason why many structures might be looking hypoechoic. Then is reverberation. Reverberations, I'll be showing you when I'll be showing you the needling. Then important area is the viewing angle. Viewing angle means the how we are holding it, how you are seeing it. Suppose, this is my, the observer. So suppose, sorry. So they should be in a single line, the observer, not observer, sorry, the doctor who is doing it, your volunteer or patient, and your machine. They should be in the same line, like you are a sniper, you're shooting. So what will be doing? The pointer, your target, your eye should be in the same line. Then all will be able to shoot it nicely. Otherwise, you cannot hold it in the different angle and you cannot shoot it nicely. So that is how here also your target means the patient and your screen should be in the same line. So that is the ergonomics of the scanning. That is the ergonomics when you are doing any of the procedure. Then your needling, how to visualize it, and that I'll be showing you over a phantom. So I'll be showing you on this. So see, first of all, two important thing is your in plane and out of plane. What is in plane? In plane means your probe and your needle should be in the same line so that you can visualize it. So remember always the depth width of this ultrasound beam is only how much? Only 1 millimeter. That means if your probe is like that, you'll be seeing it as a dot. If your needle is coming like this, you'll be seeing as a line. And very important thing is the angle between the probe and this angle should be less than 30 degrees. I'll be showing you that. Why? Then the ultrasound beam will be coming back to your probe and you'll be able to see it nicely. So now look at here. So this is filled with some gel, and you can see my needle. First, let me explain the reverberation. What is reverberation? And then I'll be showing you the other things. Okay, what was reverberation? So you can see this is the line, hyperechoic line. After that, there is several small hyperechoic lines. So why this happen? So this happens because that when we are, suppose this is a needle, this is a hollow pipe. So ultrasound beam is coming back from reflecting back from here. It will be looking very bright white, this line. And some of the ultrasound beam will be going down and it will be coming back here. So because of these two lines, you can see the two line of it. But again, some ultrasound come back will be going back and coming back here and again reflecting back. So this ultrasound, which is reflecting up and down and then going back, machine, it will be reaching the probe and machine later. So the machine will be thinking as if this beam is coming from the deeper structures. So what will happen? That the machine will be converting this into image and you'll be seeing the several lines below that. And that is what is reverberation. Okay, so reverberation is clear to everybody? Yes?
Yes, sir.
Okay, so now the angle, how you can see the needle best. And what is the thing? Suppose this is your ultrasound probe and your needle should be coming like this, and this angle should be 30 degrees or less. Why? So if the ultrasound beam is coming like that vertically and it will be reflecting like this, then it will be visible. But suppose your angle is, this is your ultrasound probe, your angle is like this. Then ultrasound beam will be coming like this and it will be reflecting back like this. So nothing is coming back. So your needle will not be visible. So I'll be showing you that if you're increasing the angle, then how gradually your needle is vanishing. Okay. So here you see, you can see the needle nicely. And now I'm increasing the, if I'm decreasing the angle, if I'm making horizontal, you can see very bright white. And now I'm increasing the angle. See what is happening? Gradually, with the more than 30 degree, it is vanishing. If I'm again bringing it back horizontal, then it is again nicely visible. I'm putting it down, then it is gradually vanishing. And you understood why? So if you are using a, suppose you want to go at certain depth, so you have to calculate, and accordingly your needle entry point should be such that you understand that my angle should be less than 30 degree to visualize the needle better. If I am going more close and if it is angle is much more, then I will not be able to visualize. You see, here it is able to visualize, but if I am making the angle deeper, then I am not able to visualize. So to visualize is better, one of the maneuver I told you, heel to maneuver. What is that heel to maneuver? So here, if I'm unable to see, I'm able to see it. If I'm making it like this, so if I heel to maneuver, so it becomes parallel to the needle and it is better visible. So heel to maneuver means you are changing the angle to make the is better, to make the needle visibility better. And another way to do it is you are using the ultrasound needle. This is an ultrasound needle. So here the reflection, this is the okay. So this is the ultrasound needle. So here the needle is such rough surface so that it is better visible. So I'll be showing you here the difference between these two. So you see here the needle visibility, here the angle is motion or not that visible. If I'm changing the angle, it is visible. But you see at this angle also, this ultrasound needle is better visible. See? In this angle, it is visible very nicely. Let me increase the depth a little bit. Okay, so you see, this is the ultrasound needle. Earlier, I have shown you that when I'm decreasing the depth, the angle, needle is visible. But when I'm increasing the angle, you see, still it is visible. Still it is visible. So it is more than 45 degree. Still it is visible. So this is the difference with the ultrasound needle. Why? Because in the ultrasound needle, there are certain things are there. There is a hole-like things. At this angle, it is better visible, of course, because it is less than 30 degree. But even if I am increasing the angle gradually, still it is better. Still it is visible. The reason is this is an ultrasound needle. So here the surface is not like a mirror. So here there will be a lot of reflected, you see at this angle it is 45 degree. Still it is visible. Whereas this is the ordinary needle. So in this needle is visible. Here the reflection is smooth surface. You can see here the surface is smooth. And this, if I'm going down, it is no longer visible. At this angle, it is no longer visible. If I'm lifting it, then it is visible. Going down, it is no longer visible. So this is the difference between the ultrasound needle and the ordinary needle. Ultrasound needle, because here it is your rough surface, so that you can see the ultrasound needle much better. And another thing you can do is when you will be putting the needle, you can just make a finer movement. Like when you're doing like that, you just make a finer movement and you go like this. Then your needle visibility will be better. Don't go like this straight away. You just make finer movement and you go. Then what will happen? Your surrounded tissue will move, and even the needle is not nicely visible. Even then, you will be able to understand the trajectory. So these are the different way to, better visualization. One is, the angle. Second is ultrasound needle. Third is compression and the heel toe maneuver to change the angle with the needle and the probe. And is very fine movement when you are advancing the ultrasound needle. Then is middle manipulation. This is again very important. Suppose you are, doing the procedure, but you are not able to reach the target. You have to change the angle. So what to do? You see, needle has a bevel. Can you appreciate the bevel here? Just change this. This is blunt tip needle. So here you see the tip has a bevel, and if you are looking at the bevel, so what we need to do here? So bevel is up. If I'm rotating it, bevel is down. So here the bevel is up. If I'm rotating it, bevel is now down. Now bevel is down. So what we need to do is when you are up and down. So when you are trying to go up, then to try to, let me explain. So that suppose this is the needle, this is the bevel. So this bevel will be making it the needle like an carved needle, so that your natural tendency of this needle will be to go down. And if you wish to go up, turn it and make the bevel down. That means you try to move your needle opposite to your bevel. So keep it up or down. You can see with the ultrasound beam that where is your bevel, and accordingly you can manipulate. Another important thing is because here you cannot use a curved needle. Like in the CM guided procedure, you are using the curved needle. Here you cannot use it. Here always you have to use a the straight needle, and that is the reason why that you have to change the angle. Needle entry point sometimes we need to change it to go to the desired structures, and angle is very important. So up to this, and if you have any question, you can ask me. If you wish to show me something again, you can ask me. Otherwise, this was the very basic about the needle manipulation, about the probe manipulation, some of the basics about what we should know as a pain physician. We have tried to cover, and you can ask me. After that, Dr. Milton will be covering the PRP quickly, and then the steroid and the dextrose injection. And from subsequent classes, we'll be going to the different module like shoulder, like elbow, like wrist. Gradually, we'll be covering all those areas.
Excuse me, sir.
Yes, yes.
Sir, how to correlate with the depth of the structure and the point of needle entry from that is the distance from the probe.
That you have to calculate. Always remember that if your structure is deeper, your needle entry point should be away from the probe. Okay.
How much?
How much? It depends on how much is the depth. There is no such calculation. You have to assume it that, okay, if my structure is there and if my needle entry point is here, I'll be able to reach the target. There is no calculation that it 1 centimeter, 2 centimeter, but just this is a very simple rule that more deep is your structure, you have to go away. But sometimes it is not possible. You cannot go much away from your probe. So in that situation, what will happen? Your angle will be increasing. And as I told you, if your angle is increasing, suppose say, for example, I don't know whether are you an anesthesiologist? So suprascapular nerve blocking the suprascapular notch. So here, it is a very deep structures, maybe around 4 or 5 centimeters below. And here, if you wish to go, you have to go laterally more away from the probe. So more away from the probe is not possible. So here angle has to more. And if your angle is more, you might not be able to visualize your needle. So what is your option? 2 options I told you. One is either use an ultrasound needle so that it will be still visible, or when you will be putting your needle, just make a fine movement when you are going deep, so that the surrounded structures will be moving and you'll be able to see your needle trajectory. So coming back to your question, that what will be the angle and how much your needle entry point away from the probe, there is no simple calculation. You have to understand how deep it is, and you have to take your needle entry point accordingly.
Okay, sir. Thank you.
Sir,
Yes.
so sometimes when we do needling, we can see the needle, the proximal part of the needle, but we may not be able to see the needle tip, which is the most important part to be visualized while injecting something. And sometimes we struggle a lot in seeing the tip. The proximal part is visible, but the tip is not visible.
Yes, yes, that is also the reason of it is the needle is not exactly in plane. It is little bit of oblique. Say, for example, here I'm showing you, I'm giving you an example. So I'm holding the probe over here. You see, the whole needle is not visible. You see, when I'm holding it. So now, you see, not the whole needle visible. Some part is visible. Here I'm visualizing the tip. Here I'm visualizing the shaft. Now I'm seeing the whole needle. But now I'm not seeing the whole needle. That means your ultrasound beam is little bit of oblique. So when you are seeing that, that means look at here. Means if my needle is exactly like this, you'll be seeing the whole needle as a hyperechoic structure. But your needle is like this, then what will happen? Either you'll be able to see the shaft or you'll be able to see the tip. So when you'll be encountering that is what you told is a very common. I also have faced sometimes because of that. Sometimes exactly like this. Some part is needle is visible, but not the whole length of the needle. So in that situation, what you need to do? You make a very fine rotation, very fine clockwise and anti-clockwise rotation, and you'll be able to see it. And still, if you are not able to see, then you can use the little bit of hill to maneuver and make a very finer adjustment, because ultimately you have to visualize your needle tip, because that is reaching to your target. But what you told is that is very much true. Many times we face this kind of situation where we are unable to see that. So what is the trick? So make a very fine rotation like this and little bit of toggling like this to see your tip, and make a very fine movement to understand where is your tip. Okay.
Okay, sir. Thank you, sir.
Anything else from anybody? Okay, it is almost 8. So a lot of other topics to cover. So thank you very much again from my side. And Milton is ready. Okay, I have to make Milton co-host. Otherwise, he will not be able to share. Okay, Milton, you are co-host now. Okay, your slides are visible. Make it full screen, Milton.
So is it okay, sir?
Yes, it's okay. You can go ahead. We can hear you nicely.
Okay.
And
Thank you, sir.
the slides are also visible.
Okay. Thank you. A very good session. Just I have my lecture regarding the PRP preparation, because we know that in our practical scenario, we have used a lot of time PRP for degeneration of muscle, tendon, joint, osteoarthritis, knee, sometimes degenerative disc disease. A lot of area where actually we have actually treating this kind of new regimen. Actually, not new regimen. We have already seen these things for last 20 years. But it is using for more than, my slide is moving or not? Okay, yes. So what is PRP? So PRP means the platelet-rich plasma. The platelet-rich plasma is defined as the volume of plasma fraction of the autologous blood that has the platelet concentration above the baseline. So before doing our PRP, we have to actually calculate the baseline, or we have to actually see what is the baseline platelet concentration. It is individual, because we know that the normal range of the platelet from 1.5 to 4 lakhs. So those patients perhaps only 1.5 lakhs. So above this, it is called the above the basement or baseline. So how much concentration we have actually treated in case of the PRP. At least 4 to 5 times from its baseline. And we need around 4 to 5 ml for treating these things, for treating this any kind of pathology. So if we are see actually the history of the PhD field, because we saw that from the 1970, the first PRP infusion, after that the maxillary surgery, treatment using the ulcer, orthopedic surgery, sports surgery, and also the peripheral nerve repairing. So it's not the recent things. Actually, mid of the 20th century, and but it the more explored and more using, especially in the sports medicine, pain medicine, from after 2000. So we have to actually derivate this platelet-rich plasma by two methods. One is called the platelet concentration method, PRP concentration method. Here actually we have used the 2 time of centrifugation, centrifuge, and another is the Buffy code method. So in case of the first method, that's been the PRP centrifuge method. First we have centrifuge. It is called the slow centrifuge because here we have using the rotation is rotation means the very time is okay, but the per minute centrifugation time per minute is very low. It's around 2000 to 2200 per minute, because it's only separate from RBC to the others component like the platelet and WBC and the plasma. After separating these things, we have actually collect only the plasma part and we discard the RBC part. So now we collect these things, and another centrifuge that's called the concentration. That means here we have think that there after collecting these things, it is around the 10 ml. So in this 10 ml, we have like every ml we have around 5 lakhs of platelets. So total 50 lakhs of platelets here in the 10 ml. So after that, when the second centrifuge, because the high centrifuge or speedy centrifuge, there we have used more than 3000, like 3400 or sometimes 3200, or some books they have suggested 3600, because it needs it's depend on many factors. So these total 50 lakhs concentrated within the 4 to 5 ml. That means this 5 ml contain the 50 lakhs of the platelet. So these two separate, these two different separate is the another system, one system, and the another system that is called the Buffy code system. Here actually we have used the single centrifuge, and here actually we have making it the high centrifuge, and it makes the three part. The bottom part that is called the RBC part. In the middle, there is the Buffy code. In the Buffy code, there is the much more of the platelet with small amount of the small concentration of the WBC, and above it, that means the top part, that is low concentration of the platelets and much more of the WBC. So actually, we have collect these things in the middle part, that is called the Buffy code. But usually when we have actually see in the naked eye, it is very difficult to differentiate. So actually, what we doing in our practice, that is, we have taking 3 to 5 millimeter above the RBC and collect these things around 2 to 4 ml of the plasma. And many of the time we have used calcium ascorbine or sometimes another activators for activating the platelet, because actually activating platelet is the main things, because in the activating platelet, there is a lot of granules and a lot of the growth factors that actually helps in the angiogenesis and help for the new tissue generation. So later we'll see these things. So in case of the classification, there are many of classification like the platelet rich plasma or platelet poor plasma, liquid platelet or gel platelet platelet rich plasma. Another classification that is called the PAW classification. Here actually they have classified it and many of the segment like the basement. That means suppose my platelet count is 2 lakhs. So P1 is the below or near the 2 lakhs. When this count per ml around 7.5 lakhs, then it is called the P2. When above the 7.5 lakhs and up to 12.5 lakhs or near these things, in between these things, that is called the P3. If we have using some activator like the some factor like the thrombin or like the calcium, so they are considered is the X. If there is when we have collect the platelet rich plasma, if there is the WBC count below the baseline, that is called the B. If above the baseline, that is called the A. Suppose my WBC count is 8,000. If in 1 ml, it's less than 8,000, that is called the below level. If more than 8,000, that is called the above. After that, the neutrophil and neutrophil count also. Neutrophil is the above the neutrophil in the baseline level. So that's time is called the alpha, and below the baseline level that is called the beta. And there is the another classification, Mishra classification, that is called the leukocyte rich non-activated and leukocyte rich activated, leukocyte or non-activated, and leukocyte or non-activated and activated. And subtype, if there is the platelet count more than 5 times. Suppose my concentration, my platelet count is 2 lakhs. If it is more than 10 lakhs per ml, that is called the A. If below the 5 times, that is called the B. So now we have seen the activators. When the activate of the platelet, either exogenously or endogenously, there secretes a lot of substance like the there is the alpha granules. They have secretion from the alpha granules like the cytokines, some chemokines, and some immuno-related factors like the complement factors, like the coagulation factors, and the growth factor, like the um, platelet derivatives growth factor, and there is the angiogenesis factors also, and there is also some that dense granulation like the catecholamine, serotonin, histamine, and calcium and others. So if we have see the what is the function of these factors, there's the platelet derivative growth factors. Actually, it is help for the mitogen or mitogenesis. That means one cell divided by two, two is divided four, four is divided by eight. And then also the chemotaxis and angiogenesis also. If there is the transforming growth factor, alpha and beta, that helps the promote the extracellular matrix synthesis, the collagen synthesis, and the cell proliferation and also differentiation. And there is the another thing that is called the fibroblastic growth factor that actually help to the stimulation of the fibroblast and endothelial cell that actually promote the angiogenesis and also the proliferation also. Endothelial proliferation and angiogenesis also. And insulin-like growth factor, they also promoting the differentiation of the cells, and epithelial growth factor, they also helps in the, especially the collagen synthesis, when actually we have given it for the osteoarthritis knee and other things. And vascular endothelial growth factors, they help for the angiogenesis, cell differentiation, and collagen synthesis. So actually, what's the mechanism for platelet-rich plasma in case of the regeneration therapy? So once the platelet are activated, either it is by the exogenous or by the endogenous. The alpha granules that actually uh, secreted the growth factors, and these growth factors actually helps for the chemotaxis, angiogenesis, cell differentiation and proliferation, and healing the wound and regeneration of these things. And also there is release of the interleukin uh, interleukin 1 receptor antagonist. Actually, these antagonists actually blocking the apoptosis pathway. So morely we have see that the insulin-like growth factor along with the platelet derivative growth factor and transforming growth factor beta 1. These actually help in the maintenance balance between the synthesis and the degradation of the proteoglycan, and also it increases the proliferation of the chondrocyte. And insulin-like growth factor also synthesis the hyaluronic acid by stimulating of the synovial fibroblast. So it helps in the osteoarthritis relative change in the joint. So in total, we can see these things. These actually stimulate the mesenchymal cell, fibroblast, osteoblast, and epidermal and endodermal cell express receptor for growth factors related. Actually, they have actually secreted these things and new cell formation, differentiation, and they actually this degeneration process help to recovery near to normal. So now we have actually see how actually we have prepared. Actually, we have taken the anticoagulant. Some kids they have pre-filling anticoagulant. Actually, they have 1 ml anticoagulant in 10 ml of tube. So if we are making like for the knee osteoarthritis, we have taken 20 ml of blood. So we need at least 2 ml of SCDA. Either we can take it the normal method, normal test tube method, or we can take it in the commercial kit method. Either we can make it by the single spin or Buffy code method or double spin method. And there is also important part that is called the temperature regulation part, because platelets are more functioning uh, near 20 or 22 degrees centigrade. So during the centrifugation, there is the friction and there is increase the temperature. So the quality of the platelets may be deteriorated during the centrifugation. So temperature system also is very important part or a very good part for making this PRP also. So here we can see the first we can see the whole blood in centrifuge, and then the Buffy code method. There is the 3 layer. The bottom layer that is the RBC, and the middle layer that is called the Buffy code, and upper layer that is also the platelets, some minerals, waters, protein, and less count of the platelet also. So equipments. So when actually we have making these things, we have taking 1 centrifuge machine for 20 ml of either commercial kit or 10 ml of 2 tube-like uh, platelet processing platelet-rich plasma processing tube, that's in PRP tube. Then 18 gauge of the needle, because when actually we have taken it more than 21, that sometimes when it travels through the needle, sometimes it's broken. So before actually separating the platelet, when it is broken, many of the growth factor actually dissolving or actually separating from the main core part. So better to take the 18 or 20 gas, not more than 21 gas, and the 20 ml of syringe and the vein bed pulsation. So here, actually in my center, I have using I have three types of machine. That is pre-cooling RAMI ultra PRP machine. Here you can see the side part, that is the freezing part. So before actually starting the processing, there is the four knobs. One is the functional knobs 1, 2, 3, and 4. So first is the pre-cooling system F1. Second, actually, when actually we have given these things, that is called the separating method. After separating these things, we have logged the commercial kit like the Dr. PRP kit. After that, we have given the F3, that is actually concentrating. Here, actually, we have not to manipulate how much RCF or how much actually rotation. Here, actually, no need to actually calculate these things. That's also the presetting manner. The second machine, that is called the Doctor's PRP machine, but here is no the pre-cooling system, but here we can actually use the commercial kit like the Doctor's PRP kit. Here we can change the speed. Here the maximum speed is 6,000, so we can manipulate it when we have to need slow or the high centrifuge. We can actually manipulate these things. And here I have also the initially I have used these things, that is test tube, like when we have actually test tube for the making the PRP, that times like this test tube. Actually that times actually we have used this type of machine. Here there is no pre-cooling system. Here we have just how much spinning per minute we have selected and how much time we have just given, and then we started these things. Here we have used from left side, we can see the first one is that is called the Doctor's PRP kit. That is worldwide use these things, and the concentration of the PRP is much more higher rest of them. And the second one, that is called the PRP with ACD and also the gel. So this is the ACD and gel. So when actually gel is compact, the lower or bottom part, there is the WBC, sorry, RBC count is settled down and it cannot actually move from it part. So only it is used. So the volume is less. So only this part is separated from this part. Okay. So another that is called the vacuum tube. Here, no actually gel and no ACD. Actually, we have used these things when actually we have prepared the patient, because if we are using this tube, that time we have 2 ml of ACD we have taken inside the syringe, and we have taken 18 ml of blood, so 9:1 ratio. After that, we have using two this tube, so we can give it the 10 ml and 10 ml. So here, if there is not pre-functional method, there is very important part that is called the G-force. G-force formula, that is relative centrifugal force, this formula. So here, very important part, the rotational distance, that's in the midline from the center, how much rotational RAM, how much the length. It's one important part. So what is the length? It should be the measure. So how much RCF you given, that is there is the calculation method. This is the G force, that's been the RCF, equal the rotation per minute square. It is the pre-formulated 1.1 each 10 to the power -5 rotation in centimeter. So you can calculate how much G force or RCA you have given. Now, so different protocols for the platelet-rich plasma preparation, like the if there is the two centrifuges, like one is the soft centrifuge and the hard centrifuge. That times actually, if we have used normally we have used another 10 ml. So 10 ml. That times we need the 250 gunun G. That's the we have calculated here the G. So 250 gunun G for the 10 minutes for the fast spin. And after that, we have used 250 gunun G for the next 10 minutes. Or some authors, there's the like here the 10 9 ml, or they have actually soft centrifuge. So the 900 gunun G for the first 5 to 6 minutes, and 1500 gunun G multiply G for the next 15 minutes. So these two protocols actually we have used in our practical scenario. All. So another very important is that is the pre-procedural preparation. Many of the times, if patient is resting condition or just patient is waiting for the care, so there is no work. They're sitting in the outside of the chamber for half an hour or 1 hour. So it is the rest condition. So more than 80 to 90% platelet goes within the bones because they are not in the always in the circulation. So before the collection of the blood, we need to at least 5 to 7 minutes of walking. That times most of the platelet comes in the circulation. They are not resting in manner. So the concentration of the platelet is different if there is a patient in rest condition, if patient is in the active position or active. Another thing we need to actually absent of or no heavy meal before 2 hours of the blood collection, and better to taking 500 to 750 ml of the blood. And if we are using the tonic weight with a very pressing manner, it also destroy the quality of the platelet. Okay, so actually we have actually puncturing the vein and blood actually come. That time actually to lose the tonic weight and better to the tonic. So here we have seen the both of the technique. One is the tail tube technique. Here actually we keep our needle here, and another is the doctor's PRP. Here actually it is refilling for showing these things. Here actually we have blocking these things actually, and here actually settle down of the platelet more concentration. So we can take an it from the just bottom in between the constrict part, in just in the constrict part, in between the dumbbell part. So the post procedure consideration, we need to actually just total off of the NSAIDs because NSAIDs actually block the platelet activation. So we have to need to actually total blocking of the NSAIDs. Better to 1 month, but at least 7 to 10 days must. So the positive effect of the injection may occur within the first week. When treating the tendon, ligaments, soft tissue, and the bursa. The joint and the other osteoarthritis consideration may take up to the 6 weeks to response. And another one things, the vigorous exercise or vigorous activity, it should be prohibited first 48 hours. After 48 hours, they will actually activating the normal activity. They also can doing normal activity, but not vigorous activity. After 10 to 12 days, actually start light exercise for rehabilitation without stressful activity. Suppose there is the um, tendon injury or tendon degeneration. So if you are stressing these things, it may be the causing the further TR. So it should be stopped and return to this stressful activity after at least 6 to 8 weeks later. Okay. So effectiveness of the platelet, actually we have searching these things. It takes different and different time. So we have to need at least 3 to 4 weeks for how much actually pain subside from the baseline to now. And it may take at least 3 to 6 months for healing of the PRP. So we have to actually follow up to the 6 months also. So it's the wide range of variations. So many author actually written it is up to the 3 months. There is another book that is written up to the 6 to 12 months. So it should be the actually observe how much actually pain decrease, and another how much the functionally just before the PRP and after the PRP. So there is a lot of controversy. What is the protocols? So protocols, actually what we did in Sarodia, actually we did 2 to 3 times of the platelet rich plasma injection in the injury site or osteoarthritic site every 3 to 4 weeks alternate. So in my practical what I have actually used, that is first injection, after 3 weeks, the second injection, after 3 weeks, the third injection, that is plus minus. So mostly I have given her the time of injection, but many of the time, if there is injury is much more, if there is degeneration is much more, so I have added more than one. If now actually how much actually evidence when you are doing these things? So level 1, level 3, and level. So level 1 here actually the lateral epicondylitis, that's mean the tennis elbow, that we are commonly found in our regular chamber, regular OPD. So there is the very good effectiveness of the PRP. So then hip pain due to the osteoarthritis or any lateral tear, osteoarthritis, change in the knee, and the shoulder pain like the acromioclavicular area or any rotator cuff injury. I have also a video yesterday. I taken it for the rotator cuff injury, but unfortunately, I cannot actually transfer these things from mobile to the laptop, so I cannot show these things. Later, I will actually share in the group. Okay. So the level 2, that is that is the jump personally. Many of the time jump me. So level 2 evidence and ACL and ACL repair also level 2. So level 2 on level 2 there is the Achilles tendinitis, but very important part. Achilles is very important, very tough tissue, and it is very important tendon. So here actually tenotomy is very good for the tendon, but here we have actually very minimal tenotomy. Okay. Then the plantar fasciitis is very fantastic improvement, and the medial epicondylitis for Wolfer's elbow, and level 2, 3, that is degenerative disc disease like the spine, where actually we have doing this things. So thank you for patient sharing. If there is any questions, just give in the chat or directly ask me or sir.
There must be a lot of questions, but just one or two questions. Otherwise, what I'll be asking series to start, and we can take the question because already it is 8:30. So quickly series let the complete it. But one or two questions can be asked right now, or you can put in the chat so that Milton can answer in the chat. Milton, that will be saving
Yes,
time.
sir.
So anybody have the
Yes,
question
sir.
in the chat box, and Milton will be answering. I'll be answering, and meanwhile I'll be asking. Milton, you can stop sharing the screen, and I'll be asking series to start. So any questions, you can put in the chat. We are answering it, and at the end, we'll be taking all the question answers again. Series.
Good afternoon. Good afternoon,
Yes,
sir.
you can start. You can start.
Am I audible, sir?
Yes, you are audible.
Yes.
Nicely audible.
Good evening. Today is my last chapter is the ultrasound guided steroid and dextrose injection. Today's class is more of theoretical than practical. I have incorporated a small clip of the steroid injection, which I'll be showing in the last. So without much delay, let's go into the topic. Coming to the introduction of this topic, the performance of ultrasound guided joint and soft tissue injection is a valuable skill that can be mastered by any pain physician. And these procedures can help to relieve pain and also improve function for the patient. The ultrasound guided precise guided technique helps in precise deposition of the drugs, especially corticosteroid and dextrose, and it can be used alone as a monotherapy, or it can be used in adjunction with other therapy for the management of pain. And these procedure basically, it is essential that the techniques to be used should be thoughtfully and precisely to be done in conjunction with making the correct diagnosis of the musculoskeletal disorder. An ultrasound guided injection into the joint, bursa, tendon sheath increases the success rate to nearly 100% in experienced hand. In experts' hand, the blind placement of the tip into even a large joint may occur sometimes out of the joint in half of the time. So it is nowadays many pain physicians are shifting from CM guided technique to ultrasound guided technique because of the success rate, which is almost 100% if you are experienced enough. And during ultrasound, needle tip is guided into the target either in plain view or out of the plain view, as Dr. Suspa has already mentioned, in a live image. And direct visualization of the success or a failure of placement is seen and can also be recorded. In this picture, you can see the precise needling of the into the bursa, subdeltoid, subarachnoid bursa. The injection is being done. And in another lower picture, you can see the needle in the either in plane where the whole shaft of the needle is seen, or in the out of plane view where the tip of the needle hyperechoic area is seen. So coming to the foundational concept of injection, not only for the steroid and dextrose, but also to the PRP, we have to know this foundational concept very nicely. First is understanding the anatomy. Second is identifying the landmark where you are giving injection. And third is we have to consider whether we have to go for pharmacotherapy or intervention technique. And if you are planning to go to the intervention technique, all aseptic measures as well as universal precaution has to be taken. We have to know various indication for the indication. Contraindications are almost as important as indication. And there are some special conditions, especially for injection of steroid and dextrose. We can give local anesthesia pre-procedure before injecting the main procedural drugs. And there are lots of injectables that can be done, but I'll be more focusing on corticosteroid and dextrose. Few of the complications which are related to this topic I'll be discussing, and after the injection or procedure, few aftercare as well as documentation of the procedure will also be discussing. So understanding the anatomy, it is essential that all clinician has a complete understanding of the three-dimensional anatomy in each area that is selected for the injection. A thorough knowledge of the target area structure being a deeper understanding of the pathological process causing the patient symptom. While advancing the needle, it is important to visualize the location of the needle tip as it passes through the anatomical structures. And ultrasound also helps in precise location of the needle as well as accurate placements of the therapeutic product. Once again, as you can see in this picture here, due to the ultrasound, it is possible to be injected in the subarachnoid and subdeltoid bursa in an exact location. Otherwise, previously blind techniques were used where the injection might go to the deltoid or down to the supraspinatus. So, and before the injection, we have to understand the anatomy of the structure where we are injecting in a three-dimensional anatomy. Okay, so second is identification of the landmark. So identification of the landmark is also equally important. For each injection procedure, the physician must identify the anatomical landmarks such as various bony prominences or easily identifiable soft tissues. These landmarks are specific to each injection site. So after clinically evaluating the patient and taking the history, we should be always thinking of, we should not rush to the procedure as much as possible. First of all, pharmacotherapy and other multimodal therapy has to be tried. So these procedures should be done with a clear differential diagnosis and treatment plan in our mind and should never be done indiscriminately. And we must consider the indication, contraindications, weight of evidence in the medical literature, as Dr. Milton had already shown in PRP. We should also consider expected benefits, possible side effect of the procedure, as well as anticipated outcome. For example, if you are injecting PRP, we have to tell the patient that outcome will come after 2 to 3 weeks, and we should not expect outcome immediately after giving the injection. And clinical experience should also be considered while doing all of the procedures, not only the dextrose and steroid. So doing these procedures, we should always use aseptic and universal precaution. And when performing any invasive procedure to any patient, we should always follow the aseptic and universal precaution. And basically, medical aseptic precaution usually does not require that the procedure need to be done in a sterile operating environment. However, it does require the provider to take the necessary precaution to ensure that there is no chance of infection, infectious organisms that can be carried away from the tissue by the needle to the injecting site. So operator must always follow the non-touch technique. And injection site is cleansed with alcohol followed by iodine or sometimes chlorhexazone. And we should always use sterile probe cover while using the ultrasound probe as shown in the figure. All aseptic precaution as well as the probe should always be covered while doing the procedure. And after procedure has been completed, a clean gauze is used to wipe the site and sterile adhesive dressing is done. So these are the few indication of the steroid as well as dextrose injection. Mainly in summary, inflammatory pathologies, steroid injections are the best. And in case of degenerative pathologies or even tear or sprain of the ligament, muscle, tendon, then dextrose prolotherapy along with PRP is the best. And the yellow colored indication are all for inflammatory pathologies, and blue colored pathologies are all for degenerative tear and sprain, that is prolotherapy indication. So crystalloid arthropathy, synovitis, rheumatoid arthritis, and other inflammatory arthritis, including bursitis, tendonitis, epicondylitis, trigger point injection, and fasciitis. In these conditions, steroid can be given. And in case of, if you are thinking of giving dextrose, then degenerative pathologies such as osteoarthritis, tendinosis, neuroma, nerve entrapment syndromes, a partial muscle or ligament tear or sprain are the indication for dextrose prolotherapy. Here, previously we used to give steroid in case of nerve entrapment syndrome. Commonly, we used to give methylprednisolone and other triamcinolone. But nowadays, people are shifting to the dextrose, especially in case of nerve entrapment syndrome, and it has shown a good evidence or even better evidence than the steroid injection. So as we all know, in contraindication is also should be known to us as it provides us where not to inject and where to inject. So absolute contraindication for all of the injection where we are doing for musculoskeletal ultrasound or even in other thing is refusal of the patient. Another is uncooperative patient, infection at the site of injection, especially, and another contraindication is, especially for corticosteroid, intramuscular or intratendinous injection is absolutely contraindicated. And coming to relative contraindication, uncontrolled diabetes and coagulopathy are relative contraindication. There has been a study done by Thrombo et al. In 1998, and it was published in Journal of Arthritis and Rheumatism. Here he has shown the injection in 32 different patients where he injected the patient with steroid in joint and soft tissue. And all of these patients were taking warfarin and their baseline INR was more than 4.5. And in this study, he showed that even after 4 weeks of procedure, there was no significant hemorrhages. So this shows us that coagulopathy is not an absolute contraindication. It is a relative contraindication. If you are expert enough, then you can go for it. Or if you are novice, you can stop the drugs and then go for the injection. There are special condition when we are giving injection, like especially dextrose and corticosteroid. First of all, diabetes. In case of diabetes people, these corticosteroid injection will elevate blood sugar. So in the recent studies has shown that corticosteroid injection are safe in patient with controlled diabetes. I want to focus that the diabetes should always be controlled. The rise of blood sugar is usually minimal and it is well controlled with continuation of the usual anti-diabetic medicine that they will be taking. But close monitoring of blood sugar is mandatory for about 5 days following the injection. And another special condition is those patients who are taking anticoagulant, including aspirin, NSAIDs, and other antiplatelet drugs such as warfarin. And as I have already mentioned, the prospective cohort study in Thrombo et al. In 1998 has shown that there was no evidence of hemorrhage or bleeding 4 weeks, even after 4 weeks of injection. But here, here he has not mentioned whether the procedure was done by the expert or the novice. So for the novice people, we should be careful. But for the expert, we can go for the injection, even if the patient is under anticoagulant. Another special condition that we should always bear in mind is septic arthritis. Septic arthritis is a medical emergency. So it is a very serious condition with dire consequences. So all efforts should be made to diagnose it immediately and provide emergent hospitalization. The patient may require treatment immediately, such as surgical drainage or irrigation of the affected joint. IV antibiotics and pain control may be mandatory immediately to the patient. And common organisms that usually cause joint septic arthritis are from Neisseria group of drug and Streptococcus and Staphylococcus species of drugs. So coming to local anesthesia, so why before injection of dextrose or even corticosteroid or even PRP, the injection should be as painless as possible. So before the procedure, we can give local anesthetic either in spray or injection to the needle in introduction area as shown in the picture. So before injection, always go for locally inject the area, make it numb, and only proceed forwards. So coming to our topic today, that is injectables, I'll be discussing a few slides with corticosteroid and dextrose. So coming to corticosteroid, so those corticosteroid which are synthetically derived from hydrocortisone, we are using clinically in our practice. And coming to mechanism of action of these corticosteroid, why and how it does anti-inflammatory and decrease pain, the list is as follows. So basically, these corticosteroid inhibit the phospholipase A2 enzyme and thus decreases the inflammation. And these corticosteroid also blocks the transmission of nociceptive C fibers, which is the main pain-carrying small fibers, unmyelinated small fibers. It also has a weak membrane stabilizing action and local anesthetic action. And it also suppresses the action of nuclear factor kappa B. So this nuclear factor kappa B is responsible for release of many inflammatory cytokines. So by suppressing this nuclear factor, this corticosteroid will have a anti-inflammatory and pain reduction activity. And they are commonly injected into the inflamed bursa as well as in the joint. So, and coming to another topic, there are several different corticosteroids are commercially available in the market as shown in the picture. You can see a picture of triamcinolone, methylprednisolone, as well as betamethasone. And there are very few studies have been done that directly compare these various agents in terms of their efficacy and duration. And furthermore, no studies have been done that conclusively determine that which corticosteroid is preferred for injection in joint and soft tissue. So without good data, the selection of particular corticosteroid agent is left in the hand of individual clinician. So we may consider the medical availability of the drug, cost of the drug, past experience of the injector. Basically, if you ask me, I prefer using methylprednisolone and triamcinolone normally. If other corticosteroids are chosen, then the equivalent dose and volume of administration should be calculated, which I'll be showing in the comparison table in the next slide. So these are the various injectable corticosteroid that is available in the market, and we can choose any out of these, anything. I basically use triamcinolone and methylprednisolone. So triamcinolone acetonide is about five times more potent than hydrocortisone. Similarly, triamcinolone hexacetonide is also similarly potent, and methylprednisolone also has a 5 times more potency than hydrocortisone. And these are all intermediately soluble to the water and has a half-life of 12 to 36 hours. And betamethasone as well as dexamethasone can also be used. The potency of betamethasone and dexamethasone is about 25 times more than that of hydrocortisone, but their lipid water solubility is very less, and half-life is a bit more, that is 26 to 54 hours. Coming to the equivalent dose of various corticosteroid, so triamcinolone acetonide is usually available in 40 mg per ml vial. Similarly, triamcinolone hexacetonide is also available in 40 mg per ml. Similarly, methylprednisolone has same concentration and volume. Betamethasone acetate is available in 8 milligram per ml vial, and dexamethasone, the equipotent dose to the triamcinolone is 6 milligram per ml. So, so in this slide, basically, I'm showing you how much volume as well as how much Doses of various steroids can be used in depending in various joint and in bursa. So doses of corticosteroid that can be used generally depends upon injection site, disease process, as well as degree of inflammation. Here, as you can see in the chart, normally in knee joint we usually use 40 to 60 milligram of methylprednisolone or triamcinolone, and the volume of injection is about 1 to 4 ml. Similarly, in shoulder joint it is 30 milligram. As elbow joint it is 20 milligram, and ankle joint we usually use 20 milligram of methylprednisolone and triamcinolone. And in the interphalangeal joint, metacarpophalangeal joint, are basically a small joint. Even in facet joint, we usually use 5 to 10 milligram of steroid, and volume of injection in these small joints are very less, about 0.25 to maximum of 0.5 ml per joint. And in bursa, depending on bursa, the volume differs. Normally, volume is 0.5 to 1.5, and amount of steroid that we are using in these bursal area is about 20 milligram of either methylprednisolone or triamcinolone. And around the tendon seat, about 5 to 20 milligram of the steroids are used of volume of 0.25 to 1 or even 3 ml. And in general, the corticosteroid injection should not be repeated within 3 months period. And the repetition of injection should always be more than 3 months apart. And this is done to prevent the systemic complication of steroids, mainly hypothalamic pituitary adrenal axis suppression, as well as osteoporosis, and local articular degradation can happen if we are using too much of steroid. And if we are using depot steroid, especially dipomedrol, the maximum volume, maximum dose in 1 year, it is about 3 milligram per kg, and in lifetime it is 6 milligram per kg. So we should never cross this maximum value. Otherwise, various complications, steroid-related complication can occur. Especially the hypothalamic pituitary axis suppression is most commonly seen. So coming to another injection that we will be talking is dextrose. So dextrose is the most commonly used prolotherapy in the clinical practice, and normally the concentration ranging from 12.5 to 25% of dextrose we are using. We can also use low concentration dextrose, that is 5% or 10%, and these low concentration dextrose are usually used to inject around the nerves or around the tendon. But if you are going for prolotherapy with dextrose, then we recommend use of 12.5 to 25% of dextrose. And dextrose is considered to be an ideal proliferant because it is, first of all, it is water soluble. Second of all, it is a normal constituent of the blood chemistry. And thirdly, it can be injected in multiple area and in large quantity, unlike corticosteroids. So the mechanism of action by which the dextrose causes prolotherapy is basically, if you are injecting hypertonic dextrose, it will cause dehydration of cell and cell death or apoptosis. This will lead to local tissue edema, especially at the injected site, and it will initiate the local inflammatory cascade. This activation of local inflammatory cascade will attract various granulocytes, fibroblasts, macrophages, and these promote healing by releasing growth factor and collagen deposits. And this is accomplished when induced cytokine-mediated chemomodulation. This can lead to proliferation and strengthening of new connective tissue, especially the joint stability, and it can also cause reduction of pain and dysfunction. So in this slide, it shows the various steps of prolotherapy, where first of all, when we induce inflammation by injecting PRP or dextrose, then it will basically initiate the local inflammatory cascade, and after the inflammation, the stages of proliferation will start, and finally the remodeling will occur. So there are various complications with use of the steroids as well as with and very less with dextrose. There are systemic complication can happen, such as while injecting, patient can go to vasovagal reaction or even have a syncopal attack. Lidocaine allergies can be there, as we are using commonly mixing lignocaine with corticosteroid, and sometimes cardiac arrhythmia, seizure, flushing, increase of blood sugar, especially in case of diabetic people, can happen. There can be impaired like immune response or adrenal suppression if you are using too much of steroid. And osteoporosis is also one of the dreadful complication if you are using multiple times steroid without taking care of its maximum value. There can be local complications such as bleeding, infection, osteonecrosis. There can be ligament rupture, especially when we inject the corticosteroid directly into the ligament, which should never be done. Tendon rupture can happen, especially if you are injecting in a weight-bearing ligament and tendon, mainly Achilles tendon. So if you inject the corticosteroid directly in Achilles tendon, there can be rupture of Achilles tendon and have a devastating effect in the patient's livelihood. There can be subcutaneous atrophy, skin depigmentation, as well as pneumothorax if you are not using the ultrasound guided technique. And if you go for blind technique, pneumothorax is common following trigger point injection especially in the trapezoid muscle. There can be steroid flare after injection with corticosteroid. So after injection of steroid as well as dextrose, there are few list of things that we should take care, especially the aftercare. After the injection, we should apply pressure bandage or even sterile tape can be applied. Usually the patient is discharged after 20 to 30 minutes after the procedure, after observing the patient, because sometimes the anaphylactic reaction or delayed anaphylactic reaction can occur, or even patient can be dizzy following injection of lignocaine in a larger volume. So it is always advised to put the patient in the observation for 20 to 30 minutes after the procedure. And we should always report immediately after any adverse reaction, or if there is any primary signs of early we have to tell the patient that if there is any primary signs of early signs of inflammation, such as swelling, redness, or increase in warmth, or if the temperature rises more than 100 degrees Fahrenheit after injection, then we have to ask the patient to report to us, and appropriate measures to be taken immediately. And the anti-inflammatory action of the corticosteroid usually starts with after 24 to 48 hours after injection. So we have to tell the patient that immediately after the injection, pain will subside because of the local anesthetic effect, but pain can come back again after 2-3 hours. This is completely normal, but the corticosteroid that you have injected will act after 1 to 2 days. So these things you have to tell to the patient, otherwise patient will be anxious, and even after the injection the pain is not being subsided, so they can be very much anxious and they can be calling you repeatedly. So similarly with dextrose injection, the result of the injection will be seen after 2 to 3 weeks, like that of PRP. And patients should also be informed of applying ice to the affected area if it was a bit painful during injection. And sometimes NSAIDs or other paracetamol can also be prescribed depending upon the clinical condition of the patient. And it is all usually advised to immobilization of the affected area, but actually it is not necessary. But sometimes if the injection volume is more, or if the patient is apprehensive, then we can ask the patient to be immobilize the area of injection for a few days and restrict the heavy activity. But normal activity, that can be all of the normal activity can be done following injection of both steroid as well as dextrose. So, and the final is documentation of the procedure. It is of extreme importance to document all the procedures that we are doing to the patient. It is not only for medical record, but it is also a legal document which you will be taking to court if any adverse reaction happens. And this documentation should always start with written informed consent, and it should always include patient's position, anesthesia that you have given, steps that you have done while doing the procedure, drugs that are used for the procedure, any complication that you encounter during the procedure, and post-procedural condition of the patient has to be documented, thoroughly documented. And finally, list of the patient's instruction at the time of discharge, and the treatment plan and follow-up should also be maintained. So thank you. So this is the picture of one pathology known as retrocalcaneal bursitis. If this video plays, I would like to show you the picture of the procedure. I basically want to show you the importance of musculoskeletal ultrasound in diagnosing the disease, the role of the anatomical landmarks that you have to follow, and the precise delivery of the drug into the pathological part. So this is the video of retrocal bursitis diagnosis, as well as ultrasound guided injection of the drug.
Okay, series, can you fast forward this?
Yes, sir. It is forwarded, sir. Almost.
Okay, so bursitis is one of the area where we can go for the steroid injection. Bursitis, steroid
Yes.
action is better. And
As
it is an inflamed, so here the PRP don't have much role.
So
okay,
here
any
we
other
can,
questions regarding the PRP, dextrose, and the steroids? These are the three most important, agents what are being used nowadays, along with, of course, the local anesthetic. But again, PRP, local anesthetics are avoided. So any
Thank you very much.
questions on these three injections, three injectants? And another important thing is, all of you must be logging into the website learnpain.org/pain medicine courses. Then only you will be able to play Kahoot. Then only you will be able to see the recorded lectures. All of you must be clicking on the live, and you must have gone through that only, and registering at the Zoom. Unless you are registered in the Zoom, you will not be able to see the Zoom recordings as well. So please use it. These recorded lectures will be available throughout the course. So you can see these recorded lectures again and again as many times as you wish. And the final questions, what will be there based on these, the topics only. Whatever we are discussing, the things will be from there only. So any question to Dr. Series, Dr. Milton, or myself? Any questions if you are having, you can ask us. Otherwise, we'll be ending because it is already 9. So we'll be ending today's session. But always keep in mind, those time is 2 hours. In few days like today, we might be going long. Unless you are completing the topics nicely, and unless all the questions are answered, we will not be leaving the meeting.
Sir?
Yes?
Some of the people, they use steroid with this dextrose. Is it actually advisable? Because both are
No,
acting in a different.
No, steroid and dextrose should not be, steroid and local anesthetic can be mixed, but steroid and the dextrose should not be mixed.
Yes, sir. Thank you, sir.
And also PRP. PRP with local anesthetic should not be mixed. PRP with dextrose should not be mixed. But PRP and steroid and PRP and local anesthetic. But PRP and dextrose, whether it can be mixed or not, again, the controversies are there. Maybe it can be mixed because there is no such, but again, literature is very few in favor of PRP plus dextrose. But PRP and steroid is contraindicated, it must not be, and PRP and local anesthetic should not be mixed.
Thank you.
Anything else? Okay, another thing is, when we will be starting with the next class, next module will be your shoulder module. So shoulder module, I'll be covering the live demonstration and anatomy, and Dr. Series will be covering the pathology part. So live demonstration will be done by me. And before that, there'll be a little bit of anatomy, and Series will be covering the pathology part. Pathology means common shoulder pathologies like rotator cuff tendinopathies, like some of the bursitis, like some of the impingement, and how ultrasound might be helping us to make a diagnosis. So thank you very much. And before that next class, you can ask any question before you are starting the next session. Okay. And good night. Take the Kahoot. Kahoot link is there in the website. And your account, you go there and you take the Kahoot link. And the Kahoot link will be available only for your 2.5 days. So after 2 days, 2.5 days, the Kahoot link will not longer be available. So thank you very much. So from entire our team, Dr. Sushpa, Dr. Series, and Dr. Milton. So good night to all of you.
Good night.